We're on. Thanks so much for joining the NAMI Maryland's 40th annual conference. My name is Toon Gardeniers. I've been a board member of NAMI Maryland since 2014. I'll be your moderator for this session today. This workshop session is tobacco smoking cessation treatment for persons with mental illness, presented by Stacy Goldshall and Benjamin Eidman from Johns Hopkins Electricity Center. You can read more about our amazing presenters, including their full bios, in the digital conference program on the official conference website. Although tobacco smoking prevalence is higher among persons with mental illness than the greater population, their long-term smoking quit rates are roughly the same. There are effective treatments available that can significantly help persons with mental illness quit smoking. The presentation will provide an overview of evidence-based smoking cessation treatment for persons with mental illness, which includes the combination of behavioral counseling with a smoking cessation medication. If this is not the workshop you meant to attend, please click the back button on your browser or click on the sessions button on the left-hand side of your screen to return to the full list of workshops available. We will be addressing questions at the end of this presentation. If you have any questions as the presentation continues, please post them to the Q&A on the right-hand side of your screen. We will be reviewing questions as they come in, and if something in particular is unclear or needs to be expanded, we will ask our presenters after the presentation has concluded to answer that. We're pleased to offer closed captioning for this year's conference. Captioning is only available for attendees using a desktop. To enable captioning, please click on the CC icon below the display of your presenters at the bottom of your screen. Once you click the icon, the video displays will become smaller and you will see the captions being generated underneath. I'm using it myself. If you have any comments, concerns, or technical issues, please post them to our chat and our technical assistant will address them accordingly. So it's now my honor, my privilege to welcome our presenters for today's workshop, Stacy Goldshall and Benjamin Eidman. Over to you. Thanks very much.
Thank you so much. We will share our screen. Okay. So my name is Stacy. Ben and I are really excited to be here today to talk about smoking cessation. We know that smoking is prevalent among people living with mental illness, that it has many negative health consequences, and that there are strategies to help someone successfully quit smoking, and we hope to share those with you today. Before we get started, we wanted to note that there are no relationships to disclose. All right, so 58 years ago, the Surgeon General of the United States released the Surgeon General's Report on Smoking and Health. And since then, we've seen smoking prevalence decrease in the general population, but it still remains very high among people living with serious mental illness. And among US adults in 2019, the percentage who reported cigarette smoking was almost 2 times higher for those living with mental illness than those without. So you can see about 28.2% in those with any mental illness compared to the general population, which is around 17%. And you'll notice in the green line here that smoking rates are particularly high among people living with serious mental illness. So why is this important? Like I just mentioned, there's a high prevalence of smoking among people living with mental illness, especially those with serious mental illness. About 70% of individuals with schizophrenia and 50% of individuals with bipolar disorder smoke. Again, compare that to about 15 to 17% in the general population. We know that tobacco smoking is the single largest contributor to preventable death, and quitting smoking is the best thing that somebody can do to improve their health and overall quality of life. The good news is that people living with mental illness can quit smoking, and long-term smoking quit rates across strategies for smokers living with mental illness are roughly 30%, which is very comparable to the general population. We know that it usually takes about 5 to 6 quit attempts for someone to successfully quit smoking. And while it may be discouraging to have a quit date and not be able to fully stop smoking on that date, we know that every quit attempt is an opportunity to learn and can help move somebody towards permanent abstinence. So during this presentation, we'd like to talk about the myths versus the facts when it comes to smoking and quitting smoking in this population. We'll talk about the evidence-based practices for smoking cessation and the different approaches to quitting. We'll review the smoking cessation medication options, as well as their safety and efficacy among people living with mental illness. We will let you know about some of the free resources that are available to help someone quit. And then finally, we'll end by discussing our research team's current efforts to bring evidence-based smoking cessation practices to community mental health clinics. And that's part of our impact project. So like I've said probably a couple times already, we know that quitting smoking is the best thing someone can do for their health and that people living with mental illness can quit. But you've probably heard otherwise. So let's briefly talk about some of the myths that are out there regarding smoking in this population. The first myth is that people living with mental illness don't want to quit smoking. And the fact is that most people know that smoking isn't good for their health, and they tend to have really important reasons for wanting to quit. Some people have family members who don't want to be around them when they're smoking, or they may have a surgery coming up and they have to be smoke-free for a period of time before they can get that surgery. Or they have other health conditions like diabetes or hypertension that's made worse because of their smoking. A majority of people living with mental illness do express an interest in wanting to quit or reduce their smoking. The second myth is that quitting worsens psychiatric symptoms. And the fact is that stopping smoking actually improves depressive symptoms and can lessen anxiety. So people may feel some agitation when quitting smoking, but that's usually due to nicotine withdrawal, and those feelings are temporary. Some people may use smoking as a coping strategy for some of their psychiatric symptoms, like their anxiety or depression. So it'll be important to identify other healthier coping strategies when they're trying to quit. Myth 3, medications don't help people living with mental illness stop smoking. And then the fact is that when combined with behavioral counseling, people who smoke are 3 to 5 times more likely to quit when prescribed a medication. We also know that smoking cessation medications are extremely effective and safe to use in this population. And the last myth that we want to share is that medications should only be prescribed for smokers who are ready to quit smoking completely. And the fact is that the new standard of treatment is to offer medications to everyone who smokes, regardless of their interest in quitting at this moment in time. There are other more flexible approaches to quitting after starting a medication that are validated ways to quit. So somebody doesn't have to be ready to quit or set a quit date within the next 30 days to be offered pharmacotherapy. Even those people who are not sure about whether they want to make a change to their smoking can be offered a medication to see how that affects their smoking and their confidence in quitting. So let's talk about the steps to help somebody quit. We have 4 steps listed here, and these are based on evidence-based practices. The first is assessing current smoking status and willingness to quit. Then you want to engage someone in a discussion about their smoking and remind them that quitting is the best thing they can do to improve their health. You can also discuss treatment options. Again, even somebody who doesn't necessarily want to quit or isn't sure about quitting can still be offered treatment. Next, you want to offer treatment, and this includes both behavioral counseling and a smoking cessation medication. And then finally, you want to follow up frequently, providing ongoing counseling, checking in about smoking status, changes in smoking status, and medication adherence, and then continuing to use or prescribe medications even after someone has quit to help prevent relapse. So the first step, like I mentioned before, is assessing smoking status and willingness to quit. So if you're a clinician, a therapist, or a counselor, simply asking somebody, do you currently smoke tobacco products? So just a yes or no question. And if they say yes, following up by asking, Are you interested in quitting or reducing your smoking? And typically we ask, within the next 3 to 6 months. It can be helpful to give a time frame to help determine the next steps. If you leave it open and ask, are you interested in quitting? Most people might say yes, but they're thinking, yeah, a year from now or 10 years from now. So giving a time frame can really help determine the type of treatment plan that's offered. Regardless of the response, treatment should be offered. So asking somebody if they want to quit smoking is not always you're not always going to get a straightforward answer. We know that people may change their mind about wanting to quit or reduce smoking. With any behavior that people have been doing a long time, it's really hard to make a change. So you may ask someone today if they're interested in quitting and they say yes. The next time you see them, which could be even later on in the same day, it could be a week, a month, a couple months from now, something has happened and now they no longer have an interest in quitting, or they're not quite ready to quit at that time. So this is really common. So again, people have been smoking for a long time, and even though they know they should quit, they may also have reasons not to quit. Some people use smoking as a coping strategy for stress. For others, there may be a social component to them. If they live in a house where everyone else is smoking, it's really hard for them to be the only one who's trying to quit. It's not uncommon for people to want to quit and not want to quit at the same time, and that's ambivalence. So there are a few strategies that you can use when responding to somebody who feels ambivalent about quitting. And we have a few of those listed here. You can explore the pros and cons of smoking. So that might be a new concept, asking somebody, what do you like about smoking? Because again, people are smoking for a reason. So giving them the opportunity to express what it is that they like about their smoking. And then you can also ask them, what don't you like about your smoking? Those negative aspects might be their motivations for wanting to change. And when doing this, if you're the person asking them about the pros and cons of smoking, you can use reflections, really focusing on the reasons to change. So if somebody says to you, I know I should quit, it's been getting hard to breathe and, I'm coughing much more, I just don't know if I can do it. Instead of focusing on, oh, you're not confident or you don't think you could do this, you might say, you have some really important reasons for wanting to quit. And it'd be helpful to talk about some of the resources that can help you be successful. So again, letting them give voice to the pros and cons, and then really kind of emphasizing the reasons to change to help them move forward in the change process. You can use evocative open-ended questions. What would need to happen for you to consider making a change to your smoking? Or how might your life be different if you were to quit smoking? If somebody doesn't want to talk about their smoking at this specific moment in time, or again, they've changed their mind about wanting to quit, asking if you can follow up with them at a later time, knowing that interest can change. At the end of the day, we have to honor a person's autonomy to make choices about their health. So we know smoking isn't healthy. Most likely they know smoking isn't healthy, but each person has the option to make decisions about their own health, and we need to respect that. But we can offer support and services when somebody is willing to quit. So what if somebody is interested in quitting? It can be really helpful to identify the quit approach, because this establishes the timeline for counseling and when to start a medication. So we have two primary approaches to quitting. And again, both of these are validated ways to quit. The first is setting a quit date. And then the second approach is what we call a reduce and then quit, which is the more flexible approach to quitting. When you're setting a quit date, you're choosing a specific date when the person will stop smoking, and it's usually chosen within a 30-day, 1-month time frame. It involves very specific steps to preparing for quitting, and it can be really helpful to check in with the person to offer support both before and after the quit date. The reduce and then quit approach, again, is a more gradual approach to quitting, and because it is more gradual, it may be more appealing to people. With this approach, you're reducing the number of cigarettes smoked over a period of time. So for example, reducing the number of cigarettes by 50% over 4 weeks, and then reducing an additional 50% over the next 4 weeks. with continued reduction until the person has eventually quit. So again, this approach may be preferred by somebody who's nervous about setting a quit date right away because it does give them more time to make those changes. Anyone who's not ready to set a quit date or those who are preparing to quit can schedule what we call a practice quit. And this is a specific amount of time that the person chooses where they're not smoking. So it can be an hour, it can be a few hours, half a day, a full day. It's really an opportunity to test out some of the coping strategies they're going to use when dealing with cravings without smoking. It can also be helpful to identify challenges. What was difficult during that practice quit? When was it really hard to not smoke? What could you do differently next time? Or how could you prepare or plan better so that it's a little bit easier to get through those hours without smoking? So the practice quit is really an opportunity to learn. After the quit approach has been identified, behavioral counseling should start. And the counseling piece is where someone is really going to learn how to deal with cravings to smoke without smoking. So this is a really important component of treatment. Evidence-based behavioral counseling for smoking cessation can cover a wide variety of topics, and we have some listed here. So again, discussing the positive and negatives of smoking, talking about the health effects of smoking and the benefits of quitting, defining and identifying triggers in high-risk situations, and then identifying coping strategies to not smoke when faced with triggers in high-risk situations. Talking about the medication options, adherence to medication, and coping with side effects of nicotine withdrawal, planning for the quit date, following up from the quit date, and then once somebody has quit, talking about dealing with slips and developing a stay quit plan. So I want to highlight just a few of the behavioral counseling session topics that come up most recently. So we know that quitting smoking isn't easy. There are things and situations that come up all the time that can increase cravings to smoke. We call these triggers and high-risk situations. So triggers are people, places, things, feelings, or situations that make someone want to smoke. Waking up in the morning and having your first cup of coffee is sometimes a trigger for people. They have to have that morning cigarette with their coffee. Feeling bored or stressed may be a trigger for making people want to smoke. Being around other friends who smoke may cause somebody to want to smoke. High-risk situations are situations in which somebody is likely to smoke, and they often include one or more triggers for smoking. So going to the movies with a group of friends, and everyone usually has a cigarette before going into the movies. So that might be a high-risk situation for somebody when they're trying to quit smoking. So you can learn to cope with triggers and high-risk situations by using what we call the 4Ds. And the 4Ds is really a group of strategies that somebody can use to either delay or avoid smoking. The 4D stands for deep breathing, so taking a deep, controlled breath instead of reaching for a cigarette. Drinking water, which can help flush nicotine from the body and reduce cravings. Delaying, so waiting a few minutes when you have a craving to smoke and not reaching for the cigarette. And also doing something else, which is one of the more common strategies that people use. So finding an activity or distraction when you have a craving to smoke so that you don't smoke. So what is it that you can do during that time when you have a craving to smoke that will take your mind off smoking and get you doing something else? Identifying personal triggers in high-risk situations and really thinking through and planning for them can help people get through those situations without smoking. So this is an example activity that we've used in counseling with the consumers that we've worked with. So asking someone to list their triggers and identify options for avoiding triggers. So these could be choosing activities that can help replace smoking, like listening to music or watching a movie, going for a walk, taking the dog for a walk, doing another outdoor activity, painting, reading a book. Really, whatever somebody enjoys doing can be used as a do something else strategy to replace smoking. So now that we've kind of briefly covered the behavioral counseling piece, I also want to introduce the other component of evidence-based smoking cessation treatment, which is smoking cessation pharmacotherapy or medications. So counseling is really effective because that's going to give people the behavioral strategies they need to not smoke when they're having cravings to smoke. But pharmacotherapy is just as important as the counseling piece. It's both components are really needed to help patients or people successfully quit smoking. Like I mentioned earlier in the presentation, smoking cessation medications are safe and effective for persons living with mental illness, and we'll show some of the data related to that. Using pharmacotherapy with behavioral counseling increases a patient's chances of quitting by 3 to 5 times more compared to behavioral counseling alone. So this is a significant increase. Again, we know that it's the combination of medication plus counseling that's going to give somebody the best chance of quitting smoking. So there are 4 medication options, and these probably look familiar or you've heard of them. Varenicline, bupropion, and the nicotine inhaler are prescription medications. The nicotine patches, gum, and lozenges are over-the-counter options. So I just want to briefly go through these options, and then we'll talk about safety and efficacy of them. So varenicline reduces cravings and withdrawal symptoms by blocking the nicotinic receptors in the brain. So people have reported that smoking is less enjoyable when they're on varenicline, or the cigarettes just don't taste as good. So oftentimes, even without trying to make changes to their smoking, they find that they're smoking less because it just doesn't give them the same rewarding experience that they had before. When somebody is using varenicline, it can increase their chances of quitting by 3 to 5 times compared to not using a medication at all. With varenicline, there is a 1-week titration phase. And then after the first week, starting week 2, you're at the full dose of the medication. The potential and most common side effect of using varenicline is nausea. We've also heard people report that they may have headaches or vivid dreams. There are some strategies that people can use if they are experiencing these side effects. So taking the medication with a large glass of water or a light snack can usually help combat the nausea. If side effects are severe and persistent, the prescribing doctor can make dosing changes to the medication. So there are some options if somebody is experiencing side effects. So we always recommend, before just stopping the medication, let's try a few things to see if we can kind of work through those side effects, because we know that varenicline is the most effective treatment option. The next option listed is bupropion, or Wellbutrin, and this acts as a nicotinic receptor antagonist, and it works by decreasing the rewarding aspects of cigarettes. If somebody is using this medication, it can increase their chances of quitting by 2 to 3 times compared to no treatment at all. We recommend using bupropion with combination NRT, so using it with a patch or plus gum or lozenge, and we'll talk about those options in just a minute. The standard dosing for bupropion is 150 milligrams twice a day, and potential side effects are usually dry mouth, insomnia, and agitation. And then lastly, we have nicotine replacement therapy, or NRT. And again, these are over-the-counter medication options that administer nicotine safely to the body to help overcome cravings to smoke. So the nicotine patch is a long-acting form of NRT, and it delivers a steady dose of nicotine into the body throughout 24 hours. So somebody puts on a patch in the morning, they leave it on throughout the day, and that patch is releasing nicotine into the body throughout the day to help overcome cravings to smoke. Dosing for the patch is based on the number of cigarettes smoked a day. So for somebody smoking a pack a day, you would use the 21 milligram patch, half a pack a day, 14 milligram patch, and then less than that would be a 7 milligram patch. There are also short-acting forms of NRT, which is the nicotine gum, lozenge, and inhaler. So with these forms of NRT, they're meant to be used as people are having cravings to smoke. So when you have a craving to smoke, instead of reaching for a cigarette, try using a lozenge, a piece of gum, or the inhaler, because these forms of NRT provide an immediate burst of nicotine into the body to help overcome those cravings to smoke. These also come in different doses depending on the amount of cigarettes smoked per day. So like I mentioned earlier, there's a lot of concern that smoking cessation medication can worsen psychiatric symptoms among people living with mental illness. So you may have heard that varenicline can cause suicidal ideations or changes in mood or behavior. And what we found through a lot of research and data is that smoking cessation medications, specifically varenicline, are safe to use among people living with mental illness, and they are very effective at helping people quit. So on the next few slides, I'm presenting a little bit of data from the Eagles trial. And we're highlighting this trial because the results of this study led to the black box warning being removed from varenicline. So in this trial, which included almost 7,000 people, they also had over 3,000 people who had psychotic or mood disorders. And when comparing adverse events to smoking cessation medications, persons living with mental illness did not experience worsening psychiatric symptoms when using varenicline. There was no effective treatment with varenicline compared to no treatment in negative symptoms, manic symptoms, or depressive symptoms in varenicline versus placebo. Again, emphasizing that varenicline did not worsen psychiatric symptoms compared to no treatment. And again, evidence from the Eagles trial showed that varenicline was safe and effective, and the results of this trial led the FDA to remove the black box warning on varenicline in 2016. So how long should pharmacotherapy be used? Once a patient or somebody has successfully quit smoking, it is appropriate and recommended to continue using a medication for at least 1 month, but really as long as needed to help prevent relapse. In a study by our colleagues Eden Evans and Corey Cather, looking at this top part, people with schizophrenia and bipolar disorder who successfully quit smoking, if they continued using pharmacotherapy after they quit, they were much more likely to stay quit after 1 year compared to people who stopped using a medication. So we've heard many times that people don't want to use a smoking cessation medication because they're already taking so many medications. They just don't want to add another one to the list. So as soon as they stop smoking, that's the first thing to go. I've quit, I don't want to take this medication anymore, and they stop taking it. But again, what we found is that there's a higher rate of relapse among those who discontinued the medication after quitting, really highlighting the benefit of continuing medication even after someone has quit to help prevent relapse. Data has shown that there are no safety or health issues to continuing to use a smoking cessation medication. And in our trials, we've had people stay on varenicline for as long as 18 months to help them stay quit. So that's looking at people who have successfully quit smoking. But what if somebody's using a medication like varenicline and they haven't quit? They've tried to quit, they've had maybe 1 or 2 quit attempts, and it just didn't work out. What should you do then? And if we look at this bottom study in the Gonzalez et al. Trial, they looked at people who had been using varenicline and had not yet quit. And they found that those people who continued using medication were much more likely to stop smoking at follow-up quit attempts than those who discontinued the medication. So repeat attempts are expected, and a failed quit attempt can still be progress. People can learn what worked, what didn't work, and all of those things can help them prepare and be more successful during the next quit attempt. So continuing to use pharmacotherapy can significantly increase someone's chances of quitting, even after multiple quit attempts. So really, it's up to the person taking the medication and their prescriber. If they're seeing some benefits of the medication, but they haven't quit smoking yet, it is perfectly okay for them to continue taking the medication to increase their chances of quitting in the future. if somebody's been taking a medication for, a few months and they really haven't made any changes to their smoking, or they really haven't seen any benefits to the medication, they're not quite ready to quit right now, then it would be okay to stop the medication. But it's really a discussion worth having with the prescribing doctor. So I've spent a lot of time talking about those people who are interested in quitting and what type of treatment should be offered for them. But what if you have somebody who says they're not interested in quitting yet? So if somebody says they're not interested in quitting, that doesn't mean the conversation has to end there. We can still offer treatment. And specifically, we recommend trying a 1-month trial of varenicline. So oftentimes somebody will say that they're not interested in quitting because they just don't have the confidence that they can quit. And we found that, again, taking a medication like varenicline and telling people, don't even worry about making changes to your smoking. Smoke like you normally would and just take the medication, and we'll check in a couple weeks and just tell me if you've noticed anything different. And what people have reported is that without even trying, their cravings to smoke have decreased, or when they do smoke, the cigarettes just don't taste the same and they're just not as enjoyable. So people are finding that they're smoking less without even really trying. And this can really give somebody the confidence they need to work towards quitting. So the new standard of treatment or new guidelines for treatment really do suggest that everyone who smokes, regardless of their interest in quitting, should be offered treatment. And now I'm going to turn it over to my colleague, Ben, to talk about some of the free resources that are available.
Thanks, Stacy. So it can be really helpful to know about some of the great resources the state of Maryland provides through their smoking cessation Quitline. All resources provided through the Quitline are 100% free. And we also want to highlight that the free resources from the state's Quitline include the evidence-based combination of behavioral counseling and smoking cessation medications that Stacy had been outlining earlier in the presentation. So you can get free one-on-one counseling from coaches that work at the Quitline that have specific training in smoking cessation. Those interested in quitting can also get free nicotine replacement therapy like patches, gum, and lozenges while the Quitline supplies last. We have the Quitline number on the slide just for reference, and it is open 24/7. And then we have the Quitline, we have a link to their website, and then they also have a page of local resources that they've really nicely collated by the different counties in Maryland on the slide as well. And I think these slides should be circulated by NAMI after the event so people can access those links. Next slide. One other great resource from the Maryland Quitline that clinicians can use is their Facts to Assist form. And this is also a free resource. And the way this works is that providers or clinicians can complete this form with their clients or patients that would like to receive free services from the Quitline and then fax it to the Quitline. And now once the Quitline has received the fax, usually one of their coaches will then contact the patient or client within 2 days to facilitate their receipt of free smoking cessation services. And then what's also helpful is that after the Quitline has conducted their outreach, they'll send the provider that sent the initial fax a return fax that details the outcome of their outreach to facilitate any further follow-up on the provider's part. So it's just another really great resource from the state that we wanted to highlight. And we have the link to this form included on the slide also for reference. So we do also want to be sure to share some of the good news that underscores how quitting smoking is one of the best things someone can do for their health. So while there are a lot of negative risk factors that are associated with smoking, many of them can be improved after quitting, including some of them within minutes and weeks. So just to highlight some of them, 20 minutes after quitting, heart rate and blood pressure will begin to drop. Within a week after quitting, the carbon monoxide levels in blood drop to normal. Between 2 weeks to 3 months after quitting, circulation and lung function will improve. Between 1 to 12 months after quitting, coughing and shortness of breath will decrease. 1 to 2 years after quitting, risk of heart attack decreases significantly. 5 to 10 years after quitting, risk of mouth, throat, and larynx cancer decreases by 50%. And 15 years after quitting, risk of coronary heart disease is similar to that of a non-smoker. So yeah, we just really want to emphasize how quitting is one of the best things someone could do to improve their health, and that a lot of the negative effects associated with smoking can be reversed when quitting. So we wanted to close just by taking a few minutes to discuss the Impact Smoking Cessation Research Project that Stacy and I are helping out with at the Johns Hopkins Alacrity Center. Next slide. So just a brief overview of the study. The goal of Impact is to pilot test an implementation intervention to increase delivery of evidence-based smoking cessation treatment for smokers living with mental illness. So Stacy highlighted that there are these evidence-based practices that exist for smoking cessation that are effective, and we're really interested in studying how these evidence-based practices can be implemented broadly in the real-world community mental health clinic settings, because prior research has indicated that although these practices exist, they might not be broadly implemented yet. So we're really interested in seeing what can be done to get these widely adopted so people can be receiving the best treatment possible for their physical health with regards to smoking cessation. It has a pre and post observational design, and it's a 12-month project that we're working with 5 Maryland community mental health clinics to implement. We've already completed the project with 1 clinic. Another 2 will be completing it this month, and then we'll have 2 more hopefully completing it next spring. So, I think last slide. No. Perfect. Thank you. So because these are evidence-based treatments and research has shown they worked well over time, our study's primary outcomes are things like providers' knowledge and self-efficacy of evidence-based smoking cessation treatment, and the percentage of consumers at each clinic that are getting the evidence-based treatments. We want to evaluate whether this project can successfully help embed practices for smoking cessation treatment into providers' routine care, and really increase their knowledge and self-belief in their ability to deliver these treatments. Next slide. So in order to assist clinics implementing the project, our study team provides a variety of supports to help facilitate their adoption of these evidence-based practices. So some of these different supports include a combination of a shorter asynchronous online training with a longer in-depth live training hosted by our team smoking cessation experts. We've developed a new and unique online avatar that clinicians can use to practice their motivational interviewing skills in a simulated smoking cessation conversation. We've distributed treatment protocols and guides to the clinicians at the participating clinics that have specific guidelines for delivering the different evidence-based smoking cessation practices. So detailed information on the medications, tips on assessing smoking status and willingness to quit, handouts clinicians can use in their counseling sessions. Expert consultation is also available to all of our participants. So our team has experts in both smoking cessation counseling and pharmacotherapy that are available for any needed phone or email questions that people might have about delivering these practices. We hold monthly organizational strategy meetings with clinic leadership where our team meets with the leadership at the clinics to review data from how the implementation of the project is going and to discuss and address any clinic level barriers that might come up. So things like, if a clinic is short staffed, how is that affecting delivery of these practices? Ensuring a smooth referral process for consumers to get medication prescriptions from their prescribers. And then lastly, we have monthly coaching meetings with the clinicians at each participating site. And these are hosted by our study team's experts and are really just a structured opportunity for the participating clinicians to discuss their individual progress with implementation and receive additional training and education from the impact team's experts. So yeah, what did we review today? So just to summarize, smoking is the #1 contributor to premature mortality in America. However, there are evidence-based practices that exist, like assessing smoking status and willingness to quit, behavioral counseling, and smoking cessation pharmacotherapy that can really help consumers living with mental illness quit smoking. We have a lot to learn. There is a really big need to spread these practices to community mental health practice settings. And that's where our work with the Alacrity Center and our research with the Impact Project is at. We're really working on trying to identify what are the best ways to get these practices widely adopted. And lastly, that there are resources like the state's Quitline, among others, that can really be a great help to both consumers and clinicians when it comes to smoking cessation and trying to quit smoking. So that concludes our presentation for this morning. We just want to thank all of you for attending and give a big thank you to NAMI Maryland for organizing this fabulous conference and giving us the opportunity to present on what we think is a really important issue. So we will stick around, and if people have any questions, we'd be happy to answer them.
Thank you, Stacy and Benjamin. Appreciate it. I have one question here from Catherine Venanzi. Actually, two now. The first one is, any strategy advice in counseling treating patients who are extremely reluctant to even consider varenicline or bupropion?
So it's not uncommon.
Excuse me, let me just, I didn't realize, there's more to this question, sorry, Stacy. Especially for patients who see commercials on TV stating all the potential side effects of varenicline, and they are afraid or extremely reluctant or resistant.
Mm-hmm. Yeah, and that is not uncommon. People have seen the commercials. They've heard about, all of these negative side effects from using varenicline. What we tend to do is let people know, again, that we're going to be working with them closely, and we'll be checking in with them, especially during those first couple weeks where they're starting a medication. We're going to be checking in with them several times to find out how they're feeling. The other option is to use NRT. Using combination NRT, which is patch plus gum or lozenge, is almost as effective as using varenicline. Almost. So we know that varenicline is, the best treatment option, but dual combination NRT is also an extremely effective treatment option for anyone who is not willing to try one of the prescription medications.
Okay. Thank you. And another question from Catherine Venanzi. Do you have any strategies and advice in counseling treating patients who vape and who are extremely reluctant to quit?
So vaping comes up a lot, and the work that we've done has exclusively focused on no smoking. The strategies that are used for quitting tobacco smoking could be used for vaping. The 4 Ds, the deep breathing, delay, do something else, drink water. Those strategies could also be applied to other behaviors like vaping. So I can't speak too much to vaping just because again, our research team doesn't have much experience with that, but the counseling would be very similar to smoking tobacco products.
Okay. Thank you. So there's no other questions in the Q&A or chat. This is not really the topic that you have been speaking to, but I'm just curious whether you might have some thoughts on this. When in the NAMI family to family class, one of the topics that's covered at some point is that it is apparently for many mental health patients, nicotine is a very helpful extra support. And therefore, it's not so surprising that so many mental health patients are smokers. Can you elaborate on that? Is that true? Any other thoughts in that area, or is that not necessarily something that you guys are focused on?
Ben, do you have any thoughts on that?
Yeah, I mean, I think it is one of those readily available coping mechanisms that had been popular for not just people living with mental illness, but for the general American public. And just the fact that you could buy it, it's right then and there, it's instant. That might have something to do with, people using that for relief. Stacy, I don't know if you have anything else to add to that.
Yeah. And I think, one of the myths out there is that people living with mental illness need to smoke to help deal with their depression, their anxiety, their mood. And what we know is that smoking actually makes all of those things worse. So quitting smoking is one of the hardest. We've heard people say, I've given up alcohol, I've given up other drugs. Smoking is the hardest thing I've ever tried giving up. It is so addictive. But we know that really focusing on it and using the behavioral strategies, using the medication, people will feel better and they will be healthier if they quit.
Right. Okay. Well, thank you. There's another reaction here from Abigail Porter. Hello, thank you for a great presentation. I have a family member with SMI who is currently undergoing smoking cessation. One of the challenges has been frontline staff who do not encourage NRT. Is there a thought to incorporate frontline staff into this educational process, as they are often the first line of encounter?
Yeah, that is something I think we would love to do. It's not something we are currently doing in our impact project. Again, we're working with the clinicians in the community mental health clinics, specifically the therapists and the psychiatrists, but the frontline staff, even residential staff or, other staff who have sometimes a lot more interaction with consumers, they need to have this information too. And what they're saying should really be aligned with what the clinicians are saying. So we would love to do that. It's not something that we're currently doing, though.
Okay.
Maybe in the future. Future research.
Well, thanks for the suggestion, Abigail. Okay, I do not have any other questions, and so I'm tempted to close the session then at this point. And just to say thank you so much, Stacy and Benjamin, for your very clear presentation. Very helpful. Much appreciated. Hope you all can join in the other sessions in the conference. And so I'm just going to leave this open for now, in case anyone wants to do anything, and I will watch that. But any of you who want to leave, that's okay as well. Thanks very much.
Great. Thank you so much, everyone.
I'm sure 9 people participating, but nobody is reacting. So I'm going to stay here just in case someone pops up with a question. So thanks again. There is another question here. Do you have any recommendations on any specific clinics, providers, counselors to whom we could refer patients?
That is, I mean, I think so much of that depends on location. So, Catherine, if we could connect maybe offline, we may be able to assist you with that once we have a better idea of what exactly it is you're looking for.
Okay. And we can help to connect you guys. So just connect with NAMI Maryland, please, Catherine, Stacy. There's another question from Susan Stewart. Do you have any tips on how to get providers to be trained in shared decision-making, motivational interviewing?
Yeah, motivational interviewing is actually the style of counseling that we recommend. When we are training clinicians as part of the Impact Project, we offer them, as part of our training package, motivational interviewing training, and specifically using those MI skills when having conversations with their clients about smoking cessation. A lot of the clinics we've worked with do have offered, kind of outside of our Impact Project, brief motivational interviewing trainings. I know there are also online training options that are available, if they're not being offered through the clinic. But I don't know if that answers your question, Susan. If you're looking for resources or, training options, we'd be happy to connect with you about those.
Is it?
Yeah, maybe if you're able to connect Susan to us, we have motivational interviewing expert on our team, and we can ask her what some good resources might be.
That'd be great. Stacy and Benjamin, could you perhaps put your email address or your contact details on the screen? That might be
sure.
useful.
Is the general chat box going to work best for that?
I don't know. That depends on Susan and Catherine, I guess.
And Susan, you said it's more about getting the providers to actually take the training. Yeah. I mean, we've found that most of the clinicians that we've worked with really do have an interest in motivational interviewing. I think it's a counseling style that has been shown to be really effective, especially when you're working with people who are ambivalent about making a change. So people see the value in having that skill set. Ben, it looks like your email is in the chat now.
Okay, great.
But again, Susan, if you're looking for kind of different ways to have conversations with clinicians to get them interested in doing the training, I think we could connect you with our kind of resident motivational interviewing expert from our team. She's part of MINT, the motivational interviewing network of trainers that is world renowned. So she travels literally around the world doing MI trainings and participating in those types of events. So she might have some good insight on that.
Do you see that one, Stace?
Yeah. So Catherine, yes, our team has a few publications. We have some that are in process of being published, a few smoking cessation projects. We also have some weight management studies that have been published. And then a cardiovascular disease risk reduction trial that we did that was published a couple of years ago, which also involves smoking cessation. So we'd be happy to share those with you. If anyone's looking for resources or publications around smoking cessation counseling or pharmacotherapy options, safety, efficacy, we're happy to also provide those. So Catherine, I think we'll probably be connecting with you separately, and we're happy to send those to you.
All right, that's great. And that's what Catherine says too. All right. Anyone else? No. Well, we're pretty much to the close. Let me just tell you that thank you so much for joining us today. At the end of the conference today, you will receive an evaluation survey. And if you would like to acquire CEUs for this workshop, please submit your responses no later than Saturday, October 22nd. The next workshop session for this conference is at 11:20. Please take some time to stretch, get a drink. Thanks again for joining. Thank you, Stacy and Benjamin.
Thanks,
Thank
everyone.
you.